These sessions are, good morning, everyone. So these sessions by the Maharashtra Rheumatology Association are for the DM, DNB students and the fellows in rheumatology. And the joinees are mainly students from Maharashtra, but all over the country also. And today we have a renowned guest speaker with us. My co-chairperson is Dr. Amrita Sanna. She's a consulting rheumatologist in Mumbai and also affiliated to Sion Hospital, Mumbai. The guest speaker for today is Dr. Ruchika Goel. She's a professor of clinical immunology and rheumatology at the prestigious Institute of CMC Vellore, Christian Medical College, Vellore. And her chief interest is large vessel vasculitis. And at their center, they have over 1,000 patients in their series of Takayasu's arthritis. So today she will be delivering a talk on disease activity measurement assessment in Takayasu's. Welcome, Dr. Ruchika, and over to you. You can share your slides. Yeah.
Thank you, ma'am, for the kind introduction, and thank you to have me here. Okay, I'll just try to share my slides.
Yes.
I think the sharing is, I only have paused the sharing, is it?
We can't see anything. Prasad, you're there. Can you just sort it out?
No, I think it has paused this screening sharing. Let me just do it again.
Just again, I can try.
Now, can you see something, madam?
Yeah. Now we can see the slides. You can go to slideshow.
Yeah. Now, am I on the slideshow?
No, we are not on slideshow yet. We are just seeing the.
I don't know, how does it happen? Every time this is a problem. Because I am on the slide.
Okay.
And it's a second stop sharing and make the slideshow.
Ma'am, can you press F5 button on your keyboard?
A5, huh?
F5.
F5.
The first most line on the keyboard. F1, F2, F3, F4, F5.
Yeah, I got it. I did. I pressed F5.
No, you need to, okay, that's fine. But now you need to share your screen first. On the Zoom itself first.
All right. Okay, I've shared. Now you want me to press F5.
Yes, now press F5. Yeah, correct.
Now what can you see? Now can you?
Yeah, we can see your screen now, ma'am. Okay, we can see your screen.
But not slideshow.
Okay, ma'am, could you please press one button on the bottom right? There is a square desktop icon, monitor icon. Bottom right, make them.
I am already on the slideshow from my side.
Why it is not showing that?
Now,
okay, ma'am, can you please stop the slideshow once, ma'am?
Now, can you see the slideshow?
No, you need to select complete screen option. Entire screen option आएगा आपको. आप स्लाइड शो पहले स्क्रीन शेयरिंग बंद कीजिए ऑन Zoom. Please turn off the screen sharing first.
Okay.
Stop. Now press again screen sharing on the Zoom. Okay.
Share.
You'll get option entire screen. Current screen and entire screen. You're getting two options: current screen, entire screen.
I am getting only screens.
You need to press that using mouse first. You need to select that first.
Now.
Hang on, it is getting shared.
Now.
No, your screen is visible. Now press F5.
Is it the slideshow?
Ma'am,
Now press
unfortunately,
F5. I have pressed F5.
it is not
Still,
working.
you're seeing you're not seeing it. I do not know. It always happens. I'm so sorry, ma'am. Just give me a minute.
no problem, no problem. Just sort it. Otherwise,
Ma'am, can you see a button? There is 100% written on the bottom right of the screen, very much at the bottom right. Yeah,
yeah,
just
slide.
before 100, there is one button. Yes, please click on that.
Before 100, there's a button.
Yeah, there is a square. Yeah, there's a square button. That
No,
is
that's what.
It's not happening, ma'am.
Yeah.
This is Windows
Yeah,
7
that's
actually,
what
not
I'm
even
saying.
Windows 10. This is Windows
Yeah,
7.
no,
I think
I
just-
can see my
Just
slideshow.
press on slideshow.
She's pressing, ma'am, but it's not happening actually.
Yeah,
It's,
madam, that is all I've done.
it is crashing,
And I
ma'am.
am seeing my slideshow. It's just that you are not seeing
I-
the
I
slideshow. That
think-
is all.
I think there is an issue on the operating system itself.
To press on slideshow on this view. There is a play and then slideshow. So just press on that
Yes, ma'am,
slideshow.
there
At the top of the screen.
at the top of
Home,
the screen,
insert,
there is
design,
Wait,
animation.
I'll
slide-
pause. 1 second. I'll pause. I will do the slideshow and then I will resume. Now you see. No? No? Now
No,
what are you
ma'am, no.
getting?
No.
I don't know what is to be done with this then. Slideshow.
We can just proceed. I think it's okay.
Yeah, I think so. Yeah.
Just check if the slides are moving. Just check. Go
Yeah,
to second slide. Third
because-
slide. Yeah.
Now, madam?
Second
And
slide.
now
Yeah,
what
go
do you
back.
see?
No, we're not seeing the slideshow. Go back to
Are
the
you
first
seeing the
slide.
slideshow? I
Not the
don't know.
slideshow. We are just seeing your
Yeah,
regular
yeah,
slides. Yeah. So we'll go with this. It's okay. Can everybody see the screen now?
Nah, yeah, this will be
Is it
also
all
fine.
right?
Okay. This will
Yeah.
also be doable.
This is
no
also
issue.
good enough.
Yeah,
Yeah.
yeah.
This is
Now
all
it's
right?
come.
This is
Yeah.
manageable? This is manageable?
Yes.
Yes, ma'am,
Yes.
absolutely.
Yeah, yeah.
All right, madam.
Okay, over to you, Dr. Ruchika. Yeah.
Now it's okay?
Yeah.
Yeah, it's fine.
Yeah, so sorry about this.
No issues. Absolutely. Yeah.
Yeah, so thank you. So I'll straight away go to the talk itself. So this is basically we'll discuss in another 30 minutes the disease activity assessment. How do you assess disease activity in Takayasu arthritis? All of us know my slides are not moving.
Just tap on it.
Yeah. So Takayasu arthritis, as all of us know, it essentially involves large vessels. And what are large vessels? They are the vessels which is essentially aorta and its direct
Slide
branches.
is not
That is
moved,
what we
Dr.
call-
Ruchika. We are still on the first slide. Then go back to whatever we were doing and go on that. I think.
Now, which slide are you on, madam?
Your
First
title
slide,
slide
right?
only. Yeah.
Now,
Yeah.
now,
Title slide.
how do we
Yeah,
go
now it's
about-
come. Now it's second slide. Yeah.
Okay, I'll just leave it on that. I'll not put it on slideshow. It's just not letting me do that.
Okay.
All right. So is this all right?
Yeah, that's fine.
Okay, sure. So, as we all know, Takayasu arthritis is a large vessel vasculitis, and large vessels essentially what we understand is the aorta and its direct branches. That is what we call as large vessels. I didn't go. My God, this negotiate through this is extremely difficult. I myself can't see my slides now.
Okay.
All right. So my slides are not moving. All right. Now, is it the third slide that you're seeing?
Yes.
Okay,
Disease
fine.
course.
Sure. So how is the course of disease? So what happens is that in Takayasu arthritis, you have 3 phases. The disease goes into through 3 phases. First, you have the phase of inflammation, which is characterized by the constitutional symptoms. Then you have the phase where you start developing the vascular symptoms, which is either in the form of inflammatory features like carotidynia. You have a lot of myalgias, low backache, not myalgia, low backache, carotidynia, and you can have sometimes myocarditis and features related to myocarditis. And then the disease progresses to vascular insufficiency, which is essentially because of the narrowing of the blood vessels. So, most of the symptoms which we see typically in Takayasu arthritis are associated with the vascular insufficiency. They are the features of vascular insufficiency. And then later on, the disease goes to the burnt out phase, which is essentially where you do not have disease activity and you have only features of vascular insufficiency. So what happens in these phases, they are not like one after the other. Most of the time, in 80% of the patients, the systemic disease, the systemic features and the symptoms of vascular inflammation and insufficiency go hand in hand. And the burnt out phase, it is extremely difficult to figure out what is the burnt out phase. So essentially, the disease symptoms in Takayasu arthritis are a combination of the active inflammation, which we call disease activity, and the damage. So what is the problem in assessing the patients, in evaluating the patients with Takayasu arthritis or following up the patients with Takayasu arthritis is that the disease status is not like, a very smooth course where you have first inflammation, then damage, and then burnt out phase. The disease is characterized by multiple episodes of intermittent inflammation, which is happening throughout the course in up to 80% of the patients. So when we looked at our patients, initially in 221 patients who were followed up, we realized that only around a third of patients actually could maintain a persistently stable disease without having any evidence of inflammation through the course of the disease, with a cumulative relapse-free survival of 55%. So that is the importance of discussing how do we assess disease activity in this disease. Madam, my slides are moving, right? Hello, can you hear me?
We are on the time course, disease course slide only.
I just don't know how do we go about it.
Now it's gone further, how to assess disease activity.
Yeah, the only thing is that animation doesn't work in this if I don't do the if I don't do the slide mode, the animation doesn't occur. That is the only problem.
So it's okay because
I'll give a last try.
yeah, sure.
Now
we'll wait. Now this is your how to assess disease activity in time
sure.
slide. Yeah.
Sure. Okay. So there are three domains in which we look at the disease activity in this disease. You have the clinical domain, that is clinical symptoms and signs. Then you have the laboratory markers and imaging, and then you have the composite tools, which takes care of all these three aspects of disease to ultimately figure out whether the patient is in active disease or not. Now, clinical symptoms and signs and laboratory markers go hand in hand, and they are actually they are used simultaneously to assess disease activity. And imaging actually in all patients and all the time course is not available, so we'll discuss it separately. Okay, this is not going to work. I will. Now, let's talk about first the clinical symptoms and signs and how do you assess disease activity with the help of these signs and symptoms. So we will discuss now the clinical activity assessment tools. So all of us are aware of this ITAS 2010 score, which is actually one of the only Indian scores in any of the rheumatological diseases to assess disease activity in TAC. So what is ITAS 2010? See, ITAS 2010 is a composite clinical score. And mind you, it is the only score which doesn't use imaging as an integrated, which doesn't have an integrated imaging arm. And that is why it is a tool which is very useful in day-to-day documentation of disease activity in patients. Now, this essentially contains 6 domains with more weightage to the cardiovascular system. So you have the first domain, which is the constitutional features. Constitutional features essentially pick up the non-specific inflammation, systemic inflammation, which happens early in the course of disease. And then you have other domains like abdomen, genitourinary system, renal, nervous system. And if you look at the cardiovascular domain, it has multiple various other signs and symptoms which are scored. The most important is that the scoring actually takes care of only the new features that have either appeared or worsened during the last 3 months of the during the last 3 months during the disease course. If these features had been persistent more than 3 months and have not worsened, then you do not score them in the ITAS form. So this tool was actually devised in 2010, and it has got a very good discriminatory activity to differentiate active versus inactive disease. But what is the problem? The limitations of ITAS is that it is not able to differentiate, like there are various studies which have tried to look at this score in their cohorts to assess the performance of this score. And what they found is that the components or the symptoms and signs which are incorporated in ITAS, they are not able to clear-cut differentiate progression in the vascular disease or end organ vascular damage over time. Second thing is that the early signs of inflammation, which is essentially all those constitutional symptoms, they have been given less weightage. The regression of symptoms, it is only a score which takes care of new or worsening symptoms and signs. So the regression of signs and symptoms are not captured. There is a silent subclinical inflammation which happens in Takayasu arthritis, which somehow is not captured in ITAS. And they also, in one of the Turkish studies, they found that the agreement between ITAS and physician global assessment was not too great when it was used in external cohorts. So this tool is being revised to look at, keeping in mind all these limitations so that it can be used in a better way to assess disease activity. So now then the main thing is that how do you improve the activity assessment? So there have been a lot of studies which have looked at what are the symptoms which are reflective of activity. So as we all know, this FDG PET actually picked up the metabolic inflammatory activity in the walls of the aorta. And it is being used very routinely in many of the countries, especially in United States, to look at activity of disease in these patients. So this was a study in which they looked at only the the vascular involvement above the diaphragm. And they looked at all the symptoms pertaining to the involvement of vessels around the neck and the limb region, upper limb region. And what they found is that only carotidynia was associated with FDG PET activity. And it was less associated with angiographic damage. It was more associated with disease activity. However, the arm claudication, actually that associated very weakly with PET activity, and it was more associated with angiographic damage. There are certain signs, and they found that certain signs and symptoms, for example, you have dizziness, vertigo, which are supposed to be suggesting the vascular insufficiency in the vertebral arteries. So these symptoms they found, they were not associated with the imaging findings when they looked at the FDG PET CTs. So they actually, that means these symptoms are very non-specific and did not reflect any vertebral artery issues. Now, what about the inflammatory markers? As I told, the inflammatory markers are the integral part of disease activity assessment in this disease. So we have, as we know, currently the most routinely used ones are ESR and CRP. So when you have a raised CRP, we call it as active disease. When you have raised ESR, we call it as active disease. But these two biomarkers are pretty imperfect in Takayasu arthritis. Why? Because various studies have shown there is around 40 to 50% discordance between the inflammation, active inflammation, and the raised inflammatory markers. Up to 50% of the patients who do not have elevated ESR and CRP may have periods of clinically active disease. And also now more and more biologicals are being used. So what they have found is that the utility of CRP levels during biologic therapy, especially during tocilizumab, is very doubtful, because it has been shown that tocilizumab decreases the CRP levels and ESR levels significantly without touching the vascular inflammation. Also, there is another aspect to it, that even if there is not much of angiographic progression, up to 40% of the patients may have a persistently raised inflammatory markers during their course of follow-up without having much of a clinical significance. That is why these two markers, although they are the best available as of now for assessing the laboratory activity, but still these markers are still far from being the perfect biomarkers. Now, there have been various other biomarkers that have been used, like pentraxin 3, serum amyloid A, and many other matrix metalloproteinases. But most of these markers do not have significant, they have not been able to come to bedside till now, so I will not be discussing this. There was an interesting study wherein they looked at whether you can use interleukin 6 as a biomarker of tocilizumab treated patients, because this is definitely a common problem. So I thought I should discuss this. So this is a Chinese study in which 35 patients were followed up. And what they found is that the interleukin 6 levels do decrease after tocilizumab therapy. And more importantly, the ratio of interleukin 6 as compared to baseline, and the ratio of the interleukin 6 at 6 months as compared to baseline actually predicted the disease progression at 12 months as well as at 24 months. And the ratio less than 1.6 was actually associated with a complete response at a complete or partial response at 12 and 24 months, as compared to the ratio which was more than 1.6, indicating that probably interleukin 6 may be a biomarker which can be used in assessing the disease activity when you are longitudinally following up the patients who have been treated with biologics, especially tocilizumab. Now, coming to the imaging assessment tools, there has been a lot of development and a lot of papers on how to use imaging effectively to assess disease activity. And there is a lot of data from the NIH cohort, as well as sort of some data from the Turkish and Chinese cohort, where they have checked, they have figured out what are the ways by which you can use the imaging in assessment of disease activity. So first of all, before going to the imaging per se, what is the ideal imaging modality for an activity assessment? So what should be the characteristics? It should be able to provide assessment of disease extent. It should be able to pick up inflammation in the aortic wall, and it should also be susceptible to change. Okay, so it should demonstrate the response to treatment. If the patient is having a good response to treatment, inflammation is coming down, then the disease activity scores in the imaging also should come down. And more importantly, it should also be able to differentiate the actual activity from the concomitant atherosclerotic changes, which happens hand in hand in patients with Takayasu arthritis. So the most common, most favorite imaging tool that is being used worldwide is the CT angiogram. Why? Because it has a very good spatial resolution. The circumferential thickening of the wall exceeding 2 to 3 millimeters in aorta has been shown to be associated with disease progression. The wall enhancement on delayed image acquisition is also one of the markers which has been shown to be associated with disease activity. And more importantly, if you have an active inflammation, in many patients, you can see what is called as a double ring sign. Whereas what happens, the intima becomes dark, that is hypoenhancement. Whereas the adventitia media, whereas the active inflammation is happening, that becomes bright, it becomes white, hyperenhanced. So if you have double ring sign, that indicates disease activity. But the problem with CT angiogram, all of us are aware of, is the the contrast and the radiation, and that is why it cannot be used very repeatedly in patients when you want to assess the disease. Now, the second imaging modality is the MR angiogram. Now, MR angiogram is considered to be the most sensitive, but it is, when you have a sensitive tool, it is definitely characterized by lack of specificity. So we had done a study in which we had found that a vessel wall thickening of more than 4 millimeters in an MR angiogram suggests that there is an active disease which is ongoing. But this is one study where we have looked at, and in our study, we did not find the vessel wall edema to be correlating with progression or activity. However, there is a study, very interesting study, which has come in 2024, wherein they tried to look at what are the MRA parameters which are useful in differentiating active from inactive disease. And what they found is that the mural thickness actually did not associate with disease activity. It was the T2 weighted mural hyperintensity. That is, when you do an MRI, you do a T1 weighted image, then you do a T2 weighted image. So the T2 weighted image actually differentiated the active patients from inactive patients. What about the contrast enhancement? In this particular study, contrast enhancement was not associated with disease activity. The luminal abnormality in the form of the number of like progression, stenosis, occlusion, dilatation, aneurysm, all these also did not differ between those with active and inactive disease. So what is the take home from this? The T2 weighted mural signal, even before you inject contrast, was associated with it differentiated active from inactive disease the best. Now, in this study, actually, so what is the problem with MRA? The problem with MRA is that there are no standardized protocols. And as well as the radiologists all across the institutions, they are not very well versed about reporting of MR angiogram in patients with Takayasu arthritis. That is why it is very difficult to compare these MR angiograms serially, especially when in India, especially when the patients, they keep on jumping from one hospital to other hospital. It is very difficult. And also another issue is that the MR angiogram, it becomes, it actually, when a patient has undergone a revascularization procedure, the MR angiogram gives a lot of artifact and makes that area non-evaluable by this for any assessment. So that is why that is a problem with MR angiogram. So people are trying to basically devise some protocols. This is one particular study in which I found that there was a very nice study in which they did a T1 weighted imaging. Then they did something called as a dark blood T2 weighted imaging. And then they gave contrast to the patients, and then they looked at the early enhancement, the 4D acquisitions time, 4D flow, and then finally they looked at the delayed enhancement. So the total acquisition time of this MR angiogram was 30 minutes. And what they found is, they found in this particular study also, the two things which actually came as most significantly associated with activity was one is vascular edema, the wall edema, which we said, no, mural, the mural hyperintensities. And in this particular study, even the progression, the thickness was associated with active disease. So the more active the disease was, the more the more was the disease, inflammatory disease activity. This is basically essentially, this is the T1, then this is the black blood, or what you call dark blood MRA. Then you have the early contrast enhancement. Then you have the this is the early delayed contrast enhancement, and then you have the 4D acquisition time, and finally you have the delayed contrast enhancement. So they found that if you look at it, this what you call the early contrast enhancement as well as the dark blood MRI, they actually perform the best. Now coming to the FDG PET. So this is basically one of the very first studies in 2005, where they looked at the inflammatory activity in the walls of the aorta by using FDG PET tracer, and they graded the activity as grade 1, grade 2, and grade 3, depending on how much is the uptake. There has been a lot of work from NIH, wherein they have looked at the utility of this FDG PET as a biomarker in patients with large vessel vasculitis as such. This includes the giant cell arthritis as well as Takayasu arthritis. So they had 56 patients of large vessel vasculitis and 59 comparators. The aorta and its 11 arterial branches were assessed for the global pattern, for the FDG uptake. And what they did is they just looked at the images qualitatively, and then tried to semi-quantify that. And what they found is that the cutoff of 12 differentiated activity from inactive disease. Then they tried to score the inflammatory activity in all these 15. Basically, it was just as compared with the uptake in the liver. The grading of 0 means that there was a less than liver. The uptake was less than the liver. One was, there was no uptake. One was uptake less than the liver. 2 was that it was equal to liver, and 3 was more than the liver. So when they collated this, they found the PET was of more than 20. If a patient had a PET VAS of more than 20, there was more likelihood that the patient is going to develop future clinical relapse in the future. This is also from the same group, where they tried to look at how does the PET activity predicts the future vascular progression. Now, what is a vascular progression? Essentially, it is the decrease in the luminal diameter, increase in vascular narrowing, increase in thickness, and new vessel wall involvement. So what they found is that if one particular artery was PET active, as you can see here, then they found that that particular artery in long run actually developed more of narrowing or progression of narrowing during the follow-up. Along with the PET, when they combine this edema or the wall thickness in the plain CT, then they found that the edema or the increase in wall thickness actually was added to the discriminative activity of the PET in suggesting the vascular progression in future. This is again the same thing. When we look at the numbers, we found that if as compared with the active comparators, they found, the non-TAC comparators, they found the sensitivity of PET was 85% and specificity of was 83% in picking up a patient as having a TAC. And when they looked at the active vasculitis, but what they found is that in the patients who had clinical remission, that means when the physician scored the patient, they found the patient was in clinical remission. More than 50% of those patients still had PET activity. And the future relapse was common in patients who had a high activity as compared to the less activity in the form of PET VAS scores over a period of 15 months. That means to say PET does correlate with the angiographic progression in future. However, there are sizable, more than 50% of the patients may have a persistent PET activity without having any signs of clinically active disease, and we do not know what is the significance of that. So the problems with PET is it is sometimes non-specific. The atherosclerosis and non-inflammatory vascular remodeling also has a lot of uptake, and you have to differentiate the actual inflammatory activity from these two processes. The subclinical activity, as we have already said, that is, there is an increased PET uptake in patients with TAC during the periods of otherwise apparent clinical remission, and that is seen from different studies scored from 20% to 58%. Another problem is that when the patient is on steroids, the performance of PET decreases drastically. We also looked at, and we found when our patients were actually treated with steroids and immunosuppressants, the sensitivity of PET actually decreased to less than 40% in identifying a patient as active disease. Now, this was the FDG PET. They are most of the research is happening in how to improve the PET, because we know that PET is actually, it can pick up the inflammatory activity very well. So can we use different tracers to improve the activity in performance? So there are two studies. One is using the somatostatin receptor 2, which is called as SST2, along with PET MRI, in which essentially you use this, and there's another one which is in which you use this 68 gallium dotatate, which is essentially the SST. It also binds to the macrophages. And so what these two tracers do is that they basically bind to macrophage, pericytes, and the perivascular adipocytes in the inflamed arterial wall. And this was a very interesting study. I would suggest most of you should read this, because it's a very beautiful study which has looked at this particular PET MRI in identifying the patients with large vessel vasculitis and atherosclerosis. 27 patients were recruited, and there were 25 MI controls, that is the patients who had myocardial infarction, and 9 control subjects. So along with this this particular imaging, what the researchers did is that they also looked at the RNA sequencing from some of the biopsy specimens which were available to them. And they looked at the localization of macrophages using the same tracer in these biopsies. And what they found is that the patients in the first part, where they looked at the PET MRA in patients PET MRA study, what they found is that the patients who had active disease or grumbling disease had more of uptake as compared to the patients with inactive large vessel vasculitis. It was more as compared to patients with MI, and during the follow-up, this activity decreased over time. Then this, you can see very nicely that you can see an uptake here in the aortic wall. And the biopsy, when they looked at the biopsy, they found that the same tracer actually was seen in the places where there was infiltration with macrophages. It is a proof of concept thing, wherein they have shown that, yes, it picks up the inflammatory macrophages and other cells which are present, essentially macrophages present in the biopsy specimens of patients with active inflammation. This is another CT which in 47-year-old male, where you look at the CT angiogram, where you can see this hypoechogenic increased wall thickness. Then when they did FDG PET, then you can see this is the inflammation. But when you do this gallium dotatate PET MRI, which essentially binds to the macrophage receptors, what you see is that you definitely have an increased uptake. So this looks like a very sensitive tool to detect the active macrophage infiltration in the aortic wall. This is a myocardium. Again, when they compared it with the T2 weighted MRI here and the late gadolinium enhancement MRI, when they looked at this dotatate, they found that definitely there was an increased uptake, which indicate the active myocardial inflammation. So there are various other things. I think I'll just skip that. Now, the second important PET tracer, which is again being used, in fact, it is being used in some centers in India as well. I think in PGI as well as in Nizams, they use this to assess the inflammatory activity. So this is essentially what is known as a FAPI PET. What is FAPI? FAPI is fibroblast activation protein inhibitor. So what essentially this particular tracer does is, it actually brings out the inflammatory activity in the fibroblast. It basically picks up the inflammatory activity in fibroblast. So when there is an inflammatory fibroblast proliferation, you will have that, which is basically the pathology in active tag, you will have increased uptake. So in this, essentially, they studied large vessel vasculitis, but only 4 patients had PET. So this is essentially called as a multidimensional imaging. That is, you are using PET, and at the same time, you are using the MRA also to assess the activity. And how do you assess activity in MRA? You looked at edema, stenosis, wall thickening, and dilatation. So you can see this image wherein they can beautifully, it shows the active inflammation in the walls of the aorta. So again, all these studies have to be validated in larger patients. It is extremely difficult to do. They're very labor intensive, as well as they're very expensive studies to do. So then you have, now this is again the study by the NIH group, wherein now what they wanted to do, they wanted to objectivize this. This objectivizing different tools is essentially to use them when you are assessing the drug therapy. So they have put up a score which is known as a VAMP score, VAMP score, what you say. It is the score which assesses the inflammatory activity and PET MRI. So this is essentially, it is a research tool which they are expecting to be used in some of the clinical trials in Takayasu arthritis. So in this, 24 subjects were recruited and they underwent a total of 40 PET MRI scans. So it is called as a multi-modality imaging. You're using PET, and along with that, you're using MRI, and you're overlapping them and trying to figure out what is the disease activity. Again, the limitation in this study, only 6 patients of TAC were used, the rest were all GCA. And this study, I'll just come to this. You can see these are the active inflammation in the aortic wall when you look at the PET activity, and then you look at this as the MRI. And what do you find is that what they found is that the cumulative SUV mean total TBR scores, they were higher in patients with active disease as compared to the patients with inactive disease. Then they calculated this VAMP score, which is essentially the sum of the mean SUV TBR for all the territories. And then you look at something called as a T2 weighted mural signal in the MR angiogram. And again, the T2 weighted mural signal, which is increased in in 2 areas, in the aorta and in the great vessels. So essentially you combine the SUV, and then you, along with that, you combine what is the inflammatory signal, that is basically the hyperintensity in the aorta in the MR angiogram, and then you look at the hyperintensity in other arteries in the MR angiogram. You sum them together with some scoring system, and then finally you get the score. And when they looked at the score, they found that the higher, as you treat the patients, these scores came down during the follow-up. Now coming to a sort of less expensive, more accessible investigations which you can use to assess disease activity. One is the vascular ultrasound or the color Doppler ultrasound. In fact, we have a study from the IPGMR Kolkata group wherein they have looked at the utility of color Doppler ultrasound in assessing disease activity. And I'll tell you the essence. Basically, color Doppler ultrasound, you have something called as a donut sign or a Macroni sign. It is essentially the circumferential echogenic thickening of the vessel wall. So this is a classic pathology. The problem with this Doppler is it is good when you use it for certain arteries like carotid, subclavian, axillary, and vertebral arteries, but it is not very good to assess the arch pathology in the descending thoracic aorta, abdomen, and abdominal aorta. But it is something which can be used, especially when you have the pathology in these accessible arteries as well as in the renals for the routine assessment of patient during follow-up. You have high resolution ultrasound, wherein again they looked at this common carotid arterial wall thickening, and they found is that in active patients, you have more of this carotid wall thickening as compared to the patients who had inactive lesions. And this particular finding correlated with MR angiogram. So the Doppler ultrasound ultrasound Doppler is extremely useful for patients who have the common carotid involvement as well as the vertebral artery involvement, but it is operator dependent. It is also labor tensor. You have to have a real-time imaging. Then there's some improvement. I'll not discuss this. This is called as a contrast enhanced microbubble. It's basically a microbubble contrast, and you can do this contrast enhanced ultrasound, which is supposed to pick up the activity much better. It is able to basically delineate the active inflammation much better as compared to the normal ultrasound. Now, last part of my talk is the composite disease activity tools. So you understood, no? There are a lot of pitfalls of clinical imaging. If you assess the patients only on the basis of symptoms, signs, and some laboratory markers. But at the same time, if you use the imaging as a standalone tool, then also you have a lot of pitfalls in assessment of disease activity. So that is where we come to the composite. When both the tools or 3 tools are not working properly, can we use them synergistically to develop a better differentiate active from inactive disease. So the first composite tool is actually what we have been using for a long time. That is the NIH criteria. They use the presence of systemic features along with inflammatory markers and the symptoms of vascular ischemia, along with the typical progression in angiography, which we have already discussed. If if two of the above domains have a new onset or worsening of features, then it reflects the disease activity. It's a simple tool which is being used in most of the studies till now. Now, this is a new, it is essentially, it's a new disease activity index, which is called as a TIDI. It's Takayasu Arthritis Integrated Disease Activity Index. It is actually an improvised version of NIH tool, I must say, in which 96 patients had been studied and they were followed up and they were given a hierarchical score. Hierarchical score means when one thing is positive, then you don't go to the next, then only you go to the next. If next is positive, then only you go to the next, like that. So, and then what they found is that they found the clinic assessment of disease activity by clinical examination was the most important. That was their overarching principle. Okay. And another concept was that if you have a standalone abnormality in the imaging, or if you have standalone inflammatory markers which are raised without having clinical activity or angiographic activity, then you do not give that much of importance to the standalone activity in these two parameters. Only if you have associated clinical activity, then only you give importance to the lab and the imaging activity. So this was a 3-step process. As I told you, it's a hierarchical scoring. That means first you look at how are the clinical symptoms. Are they present within the 7 days of assessment? If yes, then you go to the acute phase reactants, and also you look at the inflammatory activity in the aorta. They used PET essentially in the specific arterial trees. And then specific arterial tree means, suppose if you have, let's say, new onset claudication, then you look at the subclavian. Is it actively lighting up? You look at the axillary. Is it actively lighting up? And then after that, you score the items by giving 1 point to each clinical symptom present in step 1. That correctly pairs with the PET activity in the corresponding arterial tree. That means, suppose if you have claudication and if you do not have PET uptake, you do not score that clinical system. Similar way, clinical symptom. Similar way, if you have a PET activity but you do not have clinical symptom in that artery, don't score that. That is what is essentially they wanted to do. And if you have constitutional symptoms, which may not have any other, like, localized pathology, so that you score only when you have an increase in the inflammatory markers. So this is a kind of activity which is called as TIDI. And when they looked at this activity in various, it's essentially all the symptoms and all the arteries are looked, they found that it has an excellent sensitivity of more than 95% and a good specificity of around 80% as compared to the physician's clinical assessment. The problem with this tool was that it was again devised in NIH, but when they tested this tool in the Turkish cohort and the Italian cohort, they found that the sensitivity actually dropped to around 40%. So they are trying to basically fine tune it to look at what is called as the PET activity, what is not called as PET activity, try to standardize the measurements of PET activity, and then improve the system again. I'll just, this I've already make you understood. Now there is last score. This is called as Korean disease activity score. Actually, this looks like a very good and a promising score in which basically 100 patients were in derivation cohort and 46 patients were in validation cohort. And what they used as a gold standard was the physician's global assessment. It essentially also has the same staged process. You look at the physician's activity. Physician's activity was defined as the presence of 2 or more of the following. Either if the patient had the signs of vascular inflammation, which is indicated by carotidynia, or they have the signs and symptoms of ongoing vascular ischemia, or they have constitutional symptoms, or they have raised markers, or they have new bruit or asymmetry in the pulse or blood pressure. So if any of two are present, then you score the patient as active according to the physician's global assessment. After that, you look at the progression in the vascular lesions on CT scan. And if you have a presence of progression of vascular lesions in the CT scan, then the patient should have at least one of or more of the above. Above means all these signs and symptoms to be called as active disease. The systemic symptoms or elevated inflammatory markers in the absence of any clinical feature directly attributable to vasculitis were not considered as active disease. And what they found is that they looked at the performance of all the four variables, and what they found is that actually when they looked at this new disease activity assessment tool, it had a better area under curve as compared to the NIH criteria, as compared to ITAS 2010, as compared to ITAS along with ESR, or ITAS along with CRP. So they found that this particular had a cutoff of more than or equal to 5 score, had a better accuracy in delineating the active disease as compared to the inactive disease. So what is the take home? The take home is, as of now, disease activity assessment is still very imperfect in Takayasu arthritis. The ITAS 2010 is the only clinical tool which is available, which it needs revision, and we are revising it. The imaging, the CT angiogram is widely available, but it is limited by the need for contrast and radiation. Ultrasound is a feasible option, but it is good for only some particular areas. The contrast enhanced MRA better capture the vessels wall edema, but the protocols are not standardized. And the FDG PET has a moderate accuracy in assessing disease activity. We have to look at the best composite tool, which is essentially going to help us differentiating the active from inactive disease. Thank you.
Thank you so much, Dr. Ruchika. It was a very elaborative and very nice talk, and especially the new tracers that have been used for PET scans and the composite tools. I think that is a way forward. So we'll just take some questions. So Amrita, you want to ask anything or your comments? Then we'll ask the students.
Yes, ma'am. Thank you, ma'am.
Yeah.
Thank you, Dr. Goel. It was a lovely presentation. And I just wanted to ask you, where do the patient-related outcome measures stand in assessing disease activity? Is there a need to develop validated Takayasu arthritis specific patient-related outcome measures? And do we have these tools available specific to Takayasu arthritis?
So there are no tools as of now which are specific to Takayasu arthritis. There was some initial study from the Turkish group along with the Professor Peter Merkel, but I think they have not carried on further on finding out, actually devising a tag specific prompts. Now, regarding the activity assessment and the correlation with prompts, I don't think there are enough studies to say that the prompts correlate with disease activity. We are doing a study. We have actually, it's a multi-centric study which is happening including CMC, where we are trying to assess, what is the relation of prompts with activity, with procedures, and all these things. You have to wait for the results to come.
Thank you. Also, I wanted to ask you, considering the discordance between symptoms, inflammatory markers, and the imaging findings, what is the best way to define a disease relapse or a flare?
So I honestly do not know what is the best way and how the tide is going to turn the next moment, however, in the next few years. But as of now, the concept, there are two schools of thought. Most of these Western studies, they suggest that you should have the combination of some, if you have ischemic symptoms, then you have to substantiate that they belong to activity and not damage by either your lab markers or a PET activity, is what they suggest. Now, if you have the non-specific features, then the best way again to do is to substantiate it by inflammatory markers or the activity in PET. However, none of the studies have actually shown that these are perfect. So these are perfect tools. So it all depends on the context. Like I think the only thing which we have to understand, that we should not be in a hurry to escalate the therapy without being sure that this patient is having active disease or not. So you have to use all the three modalities at different time points to figure out whether the patient has active disease or not. So what we do is that if we have a ischemic symptoms, we try to have at least one more parameter to call those ischemic symptoms or new ischemic symptoms as a surrogate of inflammation.
Dr. Nikhila, you can ask two questions, then we'll again go back to the chat box. Nikhila, yeah.
Good morning, ma'am. Thank you very much for the wonderful lecture, ma'am. So, ma'am, you were saying about the composite disease activity indices, but if we start measuring if we repeat an imaging only if the patient is clinically inactive, will we not miss patients who have subclinical disease activity? And how do we decide on treatment tapering just if you're using composite disease indices, ma'am? Like step by step.
No, so if you look at ITAS, it doesn't use imaging at all. However, all the other tools, they do put imaging arm. I mean, they stress on the imaging arm, and hierarchical step-by-step approach is not that you just do two and you don't do the third. What they're saying is that when you have three available, the algorithm for calling this as active or inactive, that is the algorithm that you have to put relevance to the clinical symptoms. If you have a vascular ischemic symptoms, then you have to take into account the other two modalities also before you finally say that this patient is having active disease or inactive disease. Now, in our institution, actually, obviously, you can't just do imaging left, right, and center, both because of the radiation first, and the second thing because of the cost. So what we do is that we try to figure out as to, what aspect of like 6 months and 1 year we can do. Like we do imaging at 6 months just to understand as to what associates with the activity in this patient. And then after that, for initial couple of years, we do yearly, and then we do it 2 yearly or 5 yearly, depending on how the patient has behaved over the past 2 or 3 years.
Yes, ma'am. So we have questions from some other residents as well. So what is the ideal time to order a follow-up repeat investigation to look for remission or disease control, as you said, 6 months?
No, ideal time is it's 6 months to 1 year, first imaging. And then after that, you can do it like, every 2 yearly, up to 3 to 4 years, and then you make it every 5 yearly. That's fine. But
Yes.
again, it all depends on if the patient has been stable, everything is fine, then why do you want to do an imaging? What are you going to gain out of that? Even if, there is also a school of thought that, see, vascular thickening begets thickening. If there is a thickening, then it will definitely, there will be some progression in the thickening, which is very likely, which may happen. So if you have a mild increase in thickening, there are some school of thought is that they do not take that as a surrogate of activity. If there is a new area or there is an increase in the extent of the thickening, that is what is taken as a surrogate of activity.
I'll just ask one question from the chat box in the meanwhile. If atherosclerosis also shows inflammatory uptake in PET CT, PET scan, how do we differentiate large vessel vasculitis from atherosclerosis? Also, how do you differentiate TB aortitis from LVV on PET CT?
So PET CT is not going to differentiate TB aortitis from LVV. It is the morphology of involvement. Like first is the context. Second thing is that, let's say if you have a diffuse uptake, and if you have, I'm talking about TB versus LVV. So if you have this saccular aneurysms, and one particular area which is lighting up very high, so those are the indications that it probably a tuberculous aortitis. if the presence of the saccular aneurysms, fusiform aneurysms, if you have one particular area which is thickened or which is inflamed, and then you have adjacent or the draining lymph nodes which are enlarged, then that is more likely to be tuberculous aortoarthritis than LVV. Again, in context, like if you're not suspecting that, then that's a different thing. Regarding atherosclerosis and G, again, if you have a concentric wall thickening, if it is a smooth narrowing, it is not like a rough narrowing, eccentric wall thickening, it is not like that, then it is more likely a Takayasu arthritis. The long lesions, contiguous lesions are again in favor of TAC rather than the atherosclerosis. So atherosclerosis, they are more having a eccentric wall thickening. They have a very irregular lumen. They have very irregular lumen. They will have more of calcifications. And in the PET also, although there is an inflammatory activity, suppose if you get a SUV of, let's say, 5, 6, it's very unlikely that it is atherosclerotic uptake. But if it's a focal uptake, then again, it may be atherosclerosis. If it is a diffuse uptake, it is more likely to be TAC, like that.
That is true for the carotid imaging also, especially ultrasound you said is very good for carotid lesions.
So ultrasound, if you have hypoechogeny, double contour sign, or what you call sausage sign or macaroni sign, then it is supposedly associated with active disease. Whereas if you have just thickening without that hypoechogenicity, which suggests the vessel edema, the vessel wall edema, then it is more likely not activity, it is more of a damage, I can say, not the atherosclerosis, or damage, which may be, yes, definitely fibrotic thickening and atherosclerosis combined.
Nayantara, you want to ask anything else regarding your question?
Calcifications, basal valve calcifications are more common in atherosclerosis as compared to TAC.
Yeah. Nayantara, anything else related? You're muted. Yeah.
Ma'am, what about osteal wall involvement? When there's osteal involvement, is that more predictive of TAC rather than atherosclerosis?
Yes. Sorry, I didn't. Especially this helps in coronaries. When you have coronary involvement, renal, these are the two places. So if you have osteal involvement, then it is more suggestive of TAC.
Dr. Nidhish Chandra has a question. In your center, what is the imaging modality at baseline and follow-up for Takayasu patient? You answered part of it. Maybe you can just and repeat imaging.
Sorry. Till now, you used to use CT angiogram. Okay. Now, a lot of stress on PET CT. So what we found is that, like, we are trying to actually standardize these follow-up algorithms. But what we are currently doing, at the first imaging, we do a PET CT angio. We have the CT angio and the PET combined available. So, and then following that, it depends if you are thinking that the patient is having an inflammation and all, then you do a PET alone, which is a low-dosed CT PET. In the sense, it will have very less radiations, only the PET contrast. According to the NIH people, they say that the radiation in the low-dose PET is actually very, very less, and it allows them to do at least a yearly imaging for some time, even in the research setting at least. So then we use, and if we are expecting that there is a significant vascular thickening, which has vascular thickening has progressed, then we go for a CT angio during the follow-up. So, but first is a combination of two. We try
after clinical remission. When do you how often do you repeat the imaging in your center?
I think I've answered that.
Yes. Okay, Nikhila, you can ask 2 more questions, then we'll go back to chat box. Yeah.
Yes, ma'am. So in a patient with Takayasu type 4 and 5 with CKD, which investigation can be safely ordered without much risk of renal injury, ma'am?
Doppler is, I feel, the best investigation, and that is what we do. If we are hard pressed and we have to really delineate further, then they can do this carbon dioxide assisted angiography. So that our conventional angiography we do, and we do this carbon dioxide associated assisted angiogram.
So
which requires less of contrast. That's what this.
So we would like to know your experience on JAK inhibitors in Takayasu arthritis.
We do not, I mean, the experience which we have is what we have already published along with the other centers. It's not a single center study. St. John's, SMS Jaipur, and some other centers, Manipal, all we had collated our patients. And we found that around 60 to 80% of the patients, they have some benefit. Again, the ballpark figure in all diseases, all therapies in Takayasu arthritis is 50 to 60%. So these patients, some will respond, some will not respond, then you go to another agent. It is like that. As of now, we don't have predictors as to who responds to which therapy.
Regarding IL-6 levels on treatment, you mentioned, so the ratio was 1.6 by 1 at 6 months and baseline. So that means it is higher after treatment at 6 months? When I
No, ma'am.
was
Yeah. Other way, it comes. So if you have a ratio more than 1.6, then it indicates that there is an active inflammation which is happening, and that this patient is going to progress further at 12 months and 24 months. That's what the thing.
TNF levels, do you recommend, are they recommended for patients on treatment? Somebody's asked.
TNF alpha levels to be associated with activity.
Steroid regimen before PET-CT. So like it should be like, they're already on steroids.
Preferably less than 5 milligram per day.
But supposing they already been started on, like steroid and they come to you a week later.
That is the limitation. We do it, but if there is no activity and we think that everything else is active, we disregard that.
Dr. Sushma Shri, she's a pediatric.
We actually do not try, we do not do PET when the patient is on steroid for at least more than 10 days, 15 days. Yes.
So then you go for CT angio.
Yes. There's no point essentially.
Okay, this is a question from Dr. Sushma Shri. She is a pediatric rheumatologist. We have a child with subclavian and radial artery involvement alone without aorta involvement. Following with Doppler, is that ideal? And how common is that? I think there's something missing in the question. Sushma Shri, would you like to repeat your question?
So isolated subclavian and radial artery involvement is what I understood. And they want to follow up this patient to see whether there is
follow up with Doppler.
If you have first angio has shown that this is what it is, then I think it's okay to follow up this patient with Doppler. But after 2 or 3 years, it will be good to do one imaging.
Yeah, Nikhila, you can continue
with MR angio. Because
with MR angio.
Yes, ma'am. So in an extracranial GCA, what should be the ideal second line agent, ma'am? Is it tocilizumab or TNF inhibitor? Which would be?
I don't think there's any differentiation per se, but the data as of now, tocilizumab, the best drug they say in GCA, the best drug they say is from the GACTA trial, it is tocilizumab. Of late, ubatacitinib has also shown to be equally efficacious in the patients with GCA. So either of these drugs more than TNF. So in GCA, as of now, tocilizumab is preferred over TNFIs.
Okay. So in a patient with single vessel involvement with involvement, should we start an immunosuppressive agent or should we give a trial of steroid first, ma'am?
It's single vessel.
The question did not mention that actually.
So that is why if they are saying this is single subclavian vessel involvement, yeah, you can wait, but you just said you will have to repeat the imaging much more earlier to understand whether this disease is a progressive disease or not. I mean, this is all my opinion. There are no, I can't back up these opinions with some studies or anything.
So, what would be the preferred therapy in a case of severe stenosis in Takayasu, ma'am? Is it balloon angioplasty or stenting? Might not be.
Again, it depends on the vessel. For example, in the renal arteries, they say the stenting is not as good as, it is preferable to do balloon angioplasty. If that fails, then only you should go for stenting. If it is abdominal aorta and descending thoracic aorta, it is good to do stents because those stents will remain patent. Carotid arteries also, it's the same thing. So it depends on the specific vessel. The type of stents also, they are different in different areas. For example, in renal arteries, when you put a bare metal stent or a drug-eluting stent. So there are different. In the aorta and all, you put covered stents. Everything is, this is essentially decided by our cardiologists. But yes, for renal arteries, they say that stents may not be very good.
Any data on pregnant patients with TAC, diagnosis and treatment?
Madam,
They
there have
present-
been studies, although I have not reviewed them very in detail. In fact, there's a study from our cohort as well, in which they found that the pregnancy outcome in TAC patients is almost same as a normal population, provided they are managed well for their blood pressure, inflammatory activity. That is
diagnosis, then you'll have to do ultrasound, etc. because radiation.
Yeah, for diagnosis, we have to do ultrasound. In one patient, I think if I remember distinctly, we had done MR because it was required. Patient was having refractory hypertension. There was a decision to be taken whether it needs to be opened urgently. Patient was having cardiac involvement and all. So in those cases, you have to take a call on.
And management, what are the drug options and sequence that you use for pregnant patients?
Pregnant patient, azathioprine is the drug of choice. If you're asking for second line, right? So azathioprine is the drug of choice in pregnant patients with steroids as low as possible. It may be 7.5 to 10, depending on disease activity. If it is not there, then why do we give? But that is our drug to go to.
Nothing else besides that.
As of now, no, ma'am. As of now, no, because the efficacy of other drugs itself is very doubtful. Anti-TNFs we can use, but I have not seen such an inflammatory activity that I have to go to anti-TNFs.
How long steroids should be given in patients with TAC? As sometimes on tapering the steroids, patients develop symptoms in the neck or the legs, claudication symptoms.
So the low dose steroids, what we defined as 7.5 milligram or less, has been continued in patients depending on, again, center to center, 1 year to 2 years also. So 2 years, of course, not 7.5, but 5. But the general dictum is once you have reached a low dose of less than 10 milligram per kg body, per day, you got to wait before tapering it further. 1 year is a good one, 1 year to 2 years, depending on how your patient is.
Another child with celiac vessel involvement with good anastomosis being treated with adalimumab now, stable disease, when to refer for surgery?
Not required from my aspect, but if you send to, the cardiologists who are very confident, they would like to open up. But if you have good collaterals and the inflammatory activity is controlled and is not progressing, celiac artery is okay. You're more bothered. In fact, you have a SMA involvement.
Okay, I think we finished the chat box question. Any other questions, anybody? Ashish from Hinduja, as I can see.
I can see one which is better, anti-TNF for IL-6 as an induction therapy.
That's just come, yeah.
Yeah. So as of now, the data suggests both are equal in efficacy. But if you ask me if I'm very desperate, then I will take anti-IL-6 therapy, provided the patient can continue it for long, as long as you want them to. Otherwise,
yes. Anybody else want to ask any questions? Dr. Avinash, you're there. Avinash Jain was there. Dr. Lalana, any more questions?
Avinash can comment. He can't ask questions.
But I don't see
expert comment.
Yeah, I think he's just logged out. I think. Yeah. Another question. Just I think we'll take this last one. Have you observed thrombosis in TAC?
Yes, we have seen the patients with thrombosis, because if you have an active inflammation again and the vascular stenosis, definitely you have a decreased flow. I mean, you have a turbulence, and the turbulence can lead on to thrombosis. Another thing is that some patients, I don't remember exactly the percentage per se, have a concomitant antiphospholipid antibodies also. And then third thing is, what what did I say? Yeah, there's one more thing which we see. I'll just tell you.
Thrombosis,
Yeah, if you have
thrombosis.
a hyperhomocysteemia and other coagulant factors, so that can lead on to this thing.
Yeah.
Role of antiplatelets, again, there is one study in which they have shown aspirin is useful, but there are another study in which they have said that antiplatelets do not have much role. But if there is a CNS disease, if the patient has already had some procedure done, then I think giving antiplatelets is a sensible option.
There's also a question whether you use pentoxifylline
No.
along with anti.
No, not, I mean, I don't have any experience. This is all my experience, and I don't remember of any data as well.
So any specific precautions when you observe aneurysms regarding medications, aneurysm patients?
It should not progress. That is all I will say, because then it can lead on to rupture and dissections. That is the main thing. So the aneurysm should not progress. Then if you have a thrombosis associated with aneurysm, I don't think anticoagulation should be opted, because again, there is a chance of rupture. So these are the only two things which I can think of.
Okay. I think we had
ma'am,
yeah, Dr. Shyam, yeah.
yes. Good morning, ma'am. Thank you for the wonderful lecture, ma'am. So I have two questions. So, ma'am, it is a well-known fact that Takayasu arthritis is a T-cell mediated disease. But there are also evidence that up to 80% of the cases, they may have anti-endothelial antibodies, which may be contributing to the wall damage, means the cell wall damage. So is there any role of B-cell depletion therapy in such cases? And my second question is, ma'am, what are the indications? When do we start antiplatelet in a case of Takayasu arthritis, ma'am?
So, I'll ask the last question first. Antiplatelets, when do we start? See, if the patient has undergone any procedure, then you have to give antiplatelets. I cannot back this up with any study, but if you have the cerebrovascular involvement, then yes, antiplatelets are required. As such, the cardiovascular mortality is more in Takayasu arthritis, and there is an associated thrombosis also. And I have not seen any study which shows that antiplatelets have a detrimental role in the disease. So, if you have an extensive disease involving carotids, then I think again it is rational to start the antiplatelets. Then, sorry, just remind me, just what was your first?
Yes,
B-cell and
yes,
B-cell mediated. So,
yes, ma'am.
yeah, so the B-cell mediated, actually, they had looked at rituximab in, I think, 3 patients in one study, in which they found one patient improved, the other 2 patients did not improve, or the other way. The data did not look very promising that time. So, and you have an extensive B-cell infiltration actually in the aortic wall. So that is why the B-cell depletion is not come as the treatment in these patients.
Okay, thank you.
In fact, we used for one patient that time when this report came, and then we were not very happy with it. So we just left it.
Thank you.
Ma'am, I have one question to ask.
Okay.
Yeah. Yes,
So
Doctor.
in a patient with a life-threatening events with Takayasu arthritis, like stroke or aortic dissection, where the disease is likely to be active, what is the optimal balance between immediate life-saving supportive treatment or surgical or endovascular intervention and concurrent high-dose immunosuppressive therapy? So should we prioritize mechanical repair first and potentially in an inflamed vessel, or is there a role of rapid preoperative immunosuppression, which is there? The role is there to stabilize the arterial wall, but how soon can we intervene in such patients?
First is you have to make sure that the critical event is not because of because of disease activity, because most of the time it is because of damage. But if you have, I understood, if you have inflammatory markers also which are raised and your disease is active, so it depends on how pressing is the need for the procedure. For example, I would say there is one patient who came with the severe, there was one aneurysm in the carotids. They had to do the endarterectomy because there was an impending event which was going to happen. So you support that along with the immunosuppression hand in hand at that point of time. What has been shown is that in our endovascular clinic, what they had studied is they found it is not as against the normal conception where they say that the inflammatory activity at the time of aortic procedures, that is the most important. What they found is that even if you have mild inflammatory activity during that time, if you are able to manage the inflammation in the next 6 months with a good immunosuppression, the outcome is better. So if you're very much hard pressed, then you treat both things simultaneously. That is what is a dictum in any treatment in rheumatology. If you have infection and inflammation, that also you treat simultaneously. So both have to be treated accordingly. So you can't just wait for things to happen, inflammatory activity to settle, and then treat. If it's very, very urgent.
Yeah, especially coronary event, if it's an AC, acute
Yeah, you
coronary
have to.
syndrome,
You have to. You
treat.
can't
Yeah.
just wait for activity to go.
Yeah. There's one more question from pediatrics. Can vessel wall be non-circumferential in early phases? They have a child, she has a child with PUO, and this finding on CTX, irregular eccentric wall thickening involving left lateral wall of suprarenal aorta between origin of celiac trunk and superior mesenteric artery. Thin eccentric thrombosis, yeah.
I cannot say for sure, but generally it has to be a concentric wall thickening.
It's maybe infection or
Yes.
what about Behçet in these cases? Young child is too young, but
we have seen very less Behçet in our center. We do. So I'll not be able to actually pinpoint the etiology in this patient.
So what are the differentials when you get these atypical wall thickenings and all? One is, of course, infection.
Infections are the most important. Even in FMD and all, sometimes you can have a very irregular wall thickening. So FMD is another differential. But beyond that, I'm not able to kind of, then there are various other, like, but they also are more of aneurysmal component rather than the thickening per se.
Right. Okay, I think we had a very interesting discussion. Thank you so much, Dr. Ruchika. We really learned a lot and excellent talk. Yeah. Thank you for sparing your time on Sunday. A lot of thank yous in the chat box also for you from everyone.
Thank you.
Yeah, thank you. Have a great day. Thank you, Dr.
Thank you for having
Amrita,
me
for
here.
co-chairing. Yeah. Okay, have a
Thank
great
you.
Sunday, everybody. Yeah, bye.
Bye.
Thank you. Yeah.
Thank
Good
you.
day to you.
Thanks.
Yeah,
Good day.
thank you. Yeah, bye-bye.